Okay. Okay. Today we are going to discuss the glomerular lesions of the kidney. You see, kidney can be histologically, kidney can be divided into two parts, the glomerular part and the tubular part. So today we will be discussing the glomerular part. In glomerular part, two specific syndromes are very important. They are in fact the only syndromes which can happen to the kidneys. One is called nephrotic syndrome and other is called nephritic syndrome. Now you have to remember that both these are distinct clinical entity, and you have to appreciate and understand the basic features of both these syndromes. Now, nephrotic syndrome is a clinical complex. You see, whenever the word syndrome is used, it means a group of clinical features. It is a clinical complex composing of proteinuria, which is usually more than 3.5 gram or more than 3 gram per 24-hour urine collection. Hypoalbuminemia, whenever there is proteinuria, the albumin levels in the blood goes down. It is less than 3 gram per deciliter. Hyperlipidemia and edema. These four things, whenever you define nephrotic syndrome, you have to mention all these four things: the proteinuria of more than 3 grams, hyperbilinemia less than 3 grams, and hyperlipidemia and edema. And in this, you can also add another feature, which is called lipiduria. Now, what happens in the nephrotic syndrome? You have to understand this thing. Glomerular disease, it is basically a glomerular disease with a disruption of the filtration barrier. You see, I have not used the word inflammation. Whenever there is inflammation of the glomeruli, it is a class of nephritic syndrome. Here, although it is a syndrome, but the problem is in the filtration barrier, disruption of the filtration barrier. And what is the filtration barrier? It is the fenestrated endothelial cells, glomerular basement membrane, and podocytes. This we will understand by this diagram I'm showing you. Now, this is a diagram of glomerulus, afferent arteriole, efferent arteriole, and then these are the parietal epithelial cells. Between the parietal epithelial cells and the podocyte or visceral epithelial cells, there is a urinary space, which is called Bowman space. Yep, and the whole thing is enclosed in the Bowman's capsule. Podocytes are the cells, outer cells. After the podocyte, there is endothelial cells, and then the glomerular basement membrane. This thing has been enlarged in this diagram. Capillary lumen. The first layer is endothelial cells and then the podocytes. Now, in what happens in nephrotic syndrome is the disruption of this filtration barrier. Endothelial cells, podocytes, and glomerular basement. Just remember three things: glomerular basement membrane, endothelial cells, and the podocyte. Endothelial cells, the inner cells which are in contact with the blood, then the podocytes, and at the end is the glomerular basement membrane. Have you understood it? Now, whenever this filtration barrier is disrupted, it causes nephrotic syndrome. Glomeruli as such are not inflamed. It is only the disruption of the filtration barrier. Now keep this in mind. Now filtration barrier consists of two things. Either it is a size selective barrier, different if certain size filtration barrier stops certain elements which are larger in size, it's a size selective barrier. But then it is also a charge selective barrier. What is charge selective barrier? We know that albumin is negatively charged. So this barrier must be negatively charged so that it repels albumin and albumin is not filtered out. But if somehow this charge is disrupted, it can lead to the extra filtration of the protein albumin. I think I have explained it to you in best possible way. Okay, Janab. Once you understand this thing, Nephrotic syndrome, the clinical syndrome के features मैंने आपको बता दिए. And where is the basic fault is? It is the disruption of the filtration barrier consisting of endothelial cells, podocytes, and the glomerular basement membrane. This is what the basic thing is. Now, on the basis of this, we will discuss the pathophysiology, proteinuria and its classification, causes of nephrotic syndrome, symptoms and signs, investigation which are needed in the diagnosis of nephrotic syndrome, general management, and specific glomerular lesion which can lead to nephrotic syndrome will be discussed very briefly. And at the end, we will discuss the key points. Pathophysiology. Now, as I said, there is alteration in the glomerular basement membrane or glomerular filtration barrier, which leads to altered glomerular protein permeability. यानी कि प्रोटीन जो है वो जिसको वो रोकता था filtration barrier वो लीक होनी शुरू हो जाती है. When the proteins are leaked, it leads to increased loss of protein in the urine. ये भी समझ में आ गया. Once the proteins are lost in the urine, जो यू सी बेसिक ऑनकोटिक प्रेशर मैकेनिज्म के लिए एल्ब्यूमिन का होना बहुत जरूरी है. इट मेंटेन्स द ऑनकोटिक प्रेशर इन द ब्लड वेसल्स. तो डिक्रीज कोलाइड ऑस्मोटिक प्रेशर हो जाता है जिसकी वजह से डिक्रीज वैस्कुलर वॉल्यूम हो जाता है. Decreased vascular volume leads to decreased renal blood flow, which leads to increased secretion of aldosterone, leading to tubular sodium and water reabsorption and edema generation. एक तो ये mechanism हो गया. Decreased colloid osmotic pressure will lead to extravasation of fluid from the cellular blood compartment into the interstitial space, leading to edema. There are two mechanisms of edema: decreased colloid osmotic pressure leading to edema, and increased secretion of aldosterone, sodium, and water reabsorption leading to edema. This is the basic pathophysiology of nephrotic syndrome. Hyperalbuminemia leading to reduced intravascular oncotic pressure, loss of fluid into the interstitial space, increased when there is a loss of fluid into the interstitial space, increased albumin production शुरू हो जाती है. Liver tries to produce more albumin to compensate for it, but along with it, it also starts producing more lipoprotein, leading to increase in serum triglycerides and low density lipoprotein, leading to lipiduria and hypercholesteremia. Similarly, loss of fluid into the interstitial space, reduced blood volume, increased aldosterone secretion, decreased renal function, salt and water retention, leading to edema. Now, we will not be discussing this edema generation. This we will discuss at the time of lecture. You see, even with these two hypotheses, still we are not sure which theory is more applicable. And these two types of theories are projected: underfill theory and overfill theory, but this we will discuss at the time of lecture. Presently, basic pathophysiology, I have explained it to you, and how edema is generated, that I have explained it to you. Now, proteinuria is a hallmark of nephrotic syndrome. Healthy adults excrete less than 150 milligram of protein in 24 hours. And most of this consists of tam-horsal protein, which is tubular protein excreted daily, which is not detectable, also called uromodulin. And another 50% out of those 50%, 15% albumin, very limited amount, which is not detectable, and immunoglobulins and other proteins. So this 150 milligram of protein, which is normally excreted daily, 50% consists of tubular protein, and the rest 50% albumin and immunoglobulins and other proteins. Now, what are the different types of proteinuria? One is called high albuminuria or microalbuminuria. Microalbuminuria cannot be detected by dipstick. It is dipstick negative. For this, you need to do a special test, which is called test for microalbumin, quite expensive. Normally, 30 to 300 milligram per day microalbuminuria ranges from 30, anything which is more than 30 milligram is microalbuminuria. And the spot urine albumin creatinine ratio is more than 30 milligram per gram of creatinine. You see, another way of calculating nephrotic range proteinuria is the protein albumin or protein spot urine albumin and creatinine ratio, or spot urine protein and creatinine ratio. But remember this thing, it should be more than 30 milligram per gram of creatinine. Overt proteinuria is a macroalbuminuria, which is dipstick positive. In nephrotic syndrome, there is overt proteinuria. Albumin excretion is more than 300 milligram per day, and spot urine albumin creatinine ratio is more than 300 milligram per gram of creatinine. Isolated proteinuria is a benign condition. कभी कभी होता है, कभी नहीं होता, but it needs a regular follow. Transient proteinuria does happen in patients who have got fever, UTI, in children and adults. Heavy exercise can also lead to transient proteinuria, which is called orthostatic proteinuria. Upright position, morning sample usually is negative. Okay, chalo. Now, classification of proteinuria. Nephritic syndrome का proteinuria, any degree of proteinuria which is non-nephrotic, which is less than 3 gram per 24 hour, or on urine dipstick, it is less than +3, is a feature of nephritic syndrome. And in addition to that, nephritic syndrome also shows hematuria, RBC cast, hypertension, and raised creatinine. So in nephritic syndrome, renal functions are impaired, patient is hypertensive, and in addition to the proteinuria, which is non-nephrotic, you also get hematuria and RBC cast. This we will be discussing in the subsequent lecture, which will be on the nephritic syndrome. Nephrotic range proteinuria is dipstick strongly positive, that is +3. On dipstick, if you find 2+ proteinuria, it usually shows either you are treating the nephrotic syndrome, it is decreasing, or patient has got nephrotic syndrome. Albumin excretion of more than 3 gram to 3.5 gram in 24-hour urine collection, or the spot urine protein creatinine ratio is more than 3 gram per gram. This is the classification of proteinuria in nephrotic syndrome and nephritic syndrome. How to differentiate between nephrotic and nephritic syndrome. Now, what are the causes of nephrotic syndrome? Basically, you can divide it into two basic types: primary glomerular disease, यानी कि और body system में कोई problem नहीं है. It is primarily a glomerular lesion, which is called primary glomerular disease, and the secondary glomerular disease. Glomerular disease occurring because of other associated diseases, and this is called secondary glomerular. Both can lead to chronic progressive renal injury, but the progression is usually slow. If you compare, nephritic syndrome is a serious disorder, whereas nephrotic syndrome is relatively benign. Histological patterns are same in both primary and glomerular diseases. History, physical examination, along with relevant investigation to identify secondary cause. One should always try to identify secondary cause in any patient who presents with nephrotic syndrome. Primary glomerular disease, remember these 4 types of histopathological lesions: minimal change disease, which is most common in children; membranous glomerulonephritis, which is common in adults; focal segmental glomerulonephritis, which is FSGS, and the fourth one is membranoproliferative. You have to remember these 4 histopathological lesions of nephrotic syndrome: minimal change disease, membranous, focal segmental, and membranoproliferative. Now, these 4 lesions are also seen in secondary causes of nephrotic syndrome. So basically, the histopathological lesions are only of 4 types, may it be primary or secondary. In secondary, you will identify the secondary cause. Now, the secondary glomerular diseases which can cause nephrotic syndrome, remember, systemic diseases like diabetes mellitus, amyloidosis, SLE, and thrombocytopenia. These are the 4 most common secondary systemic diseases which can lead to nephrotic syndrome. Patients of diabetic nephropathy can present as nephrotic syndrome, and that's why diabetes is an important cause of nephrotic syndrome. Infections can be viral, like hepatitis B, hepatitis C, and HIV. Bacterial infections like bacterial endocarditis, syphilis, and leprosy. Parasitic infections like malaria, especially falciparum malaria and filariasis. Then there is systemic diseases. We have described four: infections, viral, bacterial, and parasitic. In an hypersensitivity reaction, it can be nephrotic syndrome can also be caused by penicillamine, NSAIDs, ampicillin, captopril, and a number of other drugs which I have not mentioned. Heavy metal poisoning like gold, mercury, and lithium, heroin addiction, poisons like bee stings and snake bite can also be a cause of nephrotic syndrome. Malignancy, carcinoma, myeloma, Hodgkin lymphoma, pregnancy, preeclampsia and eclampsia, and circulatory disturbances like renal vein thrombosis, and hereditary form of nephrotic syndrome, which is relatively rare, is Alport syndrome. But Alport syndrome usually present as nephritic syndrome. Now, what are the symptoms of nephrotic syndrome? Edema, gradual puffy eyes, face, feet, sacrum, and scrotal edema can occur anywhere, any tissue space it can occur. Anasarca is a generalized edema, gross edema all over the body. Abdominal distension because of the accumulation of fluid into the abdominal space. Shortness of breath because of pleural effusion in the pleural space. Anorexia, nausea, vomiting, generalized weakness, muscle wasting, decreased urine output. Patients of nephrotic syndrome are uh, they do have complaint of less urine, but in nephritic syndrome, they are definitely oliguric. Frothy urine, urine में झाग होता है because of the presence of proteins. Features, and in addition to these general features, there can be features of secondary causes like rash of SLE, numbness of diabetes, and etc. Or joint pains of rheumatoid arthritis. Signs are puffy face, baggy eyelids, edema feet, pitting sacral edema, scrotal edema, edema everywhere. Tachycardia because of hypovolemia, anemia, and fever. Blood pressure is usually normal or low, but in certain types of nephrotic syndrome, you may find high blood pressure, especially in patients with FSGS and MPGN. Evidence of ascites, shifting dullness, and fluid cell. Evidence of pleural effusion like decreased breath sounds, pleural rub, and dull percussion node, and features of secondary causes. Now, this is a child of nephrotic syndrome, puffy face, swollen all over. Another uh, patient of nephrotic syndrome, lady of nephrotic syndrome, male before nephrotic syndrome and development of nephrotic syndrome. What you will look at, periorbital, any space, tissue space in which there is a space, the fluid will accumulate. Periorbital, puffy pale face, lips may be swollen. Pitting edema of feet, you have to apply pressure on the shin for 1 minute and you get the pit. And this is the classical feature of nephrotic syndrome. Pitting edema, scrotal edema, pleural effusion. You can see a small amount of fluid into the pleural cavity. Massive pleural effusion. Now, what investigations are usually performed in patients of nephrotic syndrome? CBC, PT, and APTT. PT and APTT because most of the patients of nephrotic syndrome, biopsy is required. And before proceeding with the biopsy, you have to check the bleeding profile. And for that, PT and APTT are done. CBC is done to exclude other secondary causes of nephrotic syndrome. Urine DR will give you 3+ proteinuria. Hepatitis B and C to exclude secondary causes. Urea creatinine electrolyte, because patients of nephrotic syndrome, they usually do not have renal failure, but if the kidney functions are impaired, it's a serious disorder. Fasting and random blood pressure to fasting and random blood sugar to exclude diabetes mellitus. Calcium, phosphorus, alkaline phosphatase, and uric acid. These are the panel of, as I have already told, the renal profile panel. Serum protein, albumin, and globulin. You have to identify lipid profile to check for cholesterol, HDL, LDL, and triglycerides. In addition to this, you have to do a 24-hour urine protein estimation to establish that the proteinuria is more than 3.5 gram per 24 hour. Spot urine protein creatinine ratio, which should be more than 300. Ultrasound KUV and X-ray chest, because you intend to do a kidney biopsy, so you need to have an ultrasound so that you can see that a biopsy can be performed or not. And then finally, the test for secondary causes like HIV, ANA, anti-DNA to exclude SAD, C3, C4 also to exclude SLE, and protein electrophoresis to exclude multiple myeloma, and HbA1c to exclude diabetes mellitus. Now, investigation. Kidney biopsy is the most important investigation which is usually performed in all patients of nephrotic syndrome to confirm the diagnosis and to find out the histopathological lesion which is involved, like minimal change, focal segmental, membranoproliferative, etc. Extent of renal disease, how much of the kidneys are affected, how many of the glomeruli are completely damaged. And it also helps you to guide the therapy, response to the therapy, and you again have to do the kidney biopsy to assess the response. And finally, it also helps you in identifying the prognosis of a certain form of nephrotic syndrome. This is the kidney biopsy needle with which we perform kidney biopsy. This is how a kidney biopsy is done. The lower pole of kidney is located with an ultrasound, and the needle is inserted and the tissue is obtained. This doctor doing a kidney biopsy. This is called ultrasound guided kidney biopsy. Now, what are the indications for kidney biopsy? All adults with nephrotic range proteinuria, children below 1 year of age. Here I have written children below 1 year of age. You may ask, what will you do in children who are between 3 to 10 years of age? You see, patients who present with nephrotic syndrome and who are in the age group 3 years to 10 years, it is 90% minimal change disease. So we usually do not perform biopsy. We start treatment without doing a biopsy. But if somebody comes with a nephrotic syndrome and he is less than 1 year of age, kidney biopsy becomes mandatory. And in small children, kidney biopsy is usually performed under anesthesia. Then frequently relapsing nephrotic syndrome. There is a person, you are treating him with immunosuppressive drugs and steroids for that nephrotic syndrome. The moment you stop steroids or drugs, they relapse. The nephrotic syndrome again comes. And this keeps on repeating. This is called frequently relapsing nephrotic syndrome, then steroid resistant nephrotic syndrome. You are treating a patient of nephrotic. We see steroid is a gold standard for the treatment of nephrotic syndrome. And if somebody is not responding to steroid, it is called steroid resistant nephrotic syndrome. And in that case also, you need to do a biopsy. Secondary causes of nephrotic syndrome, you usually do kidney biopsy. And in nephrotic syndrome with low GFR, it means the kidneys are already damaged. Patient is hypertension and has got hematuria. So you have to identify the basic pathology responsible for these features. And for that, kidney biopsy becomes necessary. Now, what are the contraindications of kidney biopsy? Bleeding disorder, as I have already told, PT and APTT are deranged or the platelet count are low. In that situation, kidney biopsy cannot be performed. Uncontrolled hypertension, you cannot do a kidney biopsy. In severe uremia, when the creatinine is more than 4, first you have to dialyze the patient and then you have to do a diet. If there is an active infection like pyelonephritis, abscess, skin infection or pneumonia, you have to first treat that infection and then do a kidney biopsy. Solitary native kidney, somebody has got only one kidney, then kidney biopsy are usually not performed. But now since biopsy has become so safe, it can be performed, but it is usually avoided. Patients with renal neoplasm, no kidney biopsy. Cystic diseases like polycystic kidney disease, you cannot do a kidney biopsy. In pregnancy, it is usually avoided. That once the patient is delivered, only then you can proceed with the kidney biopsy. But again, in certain conditions, even if the patient is pregnant, you can do a kidney biopsy. Patients on anticoagulants, you have to stop the anticoagulants before doing the biopsy. As for on ultrasound, you find a bilaterally small shrunken kidney. The diagnosis is obvious that he has got chronic nephritis. And so in this situation, kidney biopsy is not indicated. Non-cooperative patient refuses to allow you to do a kidney biopsy, cannot force them to have kidney biopsy. Patient refusal कि भाई मैं नहीं कराऊंगा biopsy, you cannot force them to have kidney biopsy. Because for kidney biopsy, you have to take a consent. Now, what are the uh, management of nephrotic syndrome. We have already discussed the contraindications. Now we come to the management. You can divide management into two parts: general management and management of the specific glomerular lesions. General management, you have to control proteinuria. If there is hypertension, you have to control hypertension. You have to control edema, hyperlipidemia, hypercoagulability, and infections. And management of specific glomerular lesion, depending on the type of lesion, you will decide. Proteinuria, decrease proteinuria to non-nephrotic proteinuria, because protein, the larger the amount of protein, the more chances of glomerular damage. So you have to decrease the proteinuria, and for this, ACE and ARB are the drug of choice. They inhibit renin-angiotensin aldosterone system. They decrease glomerular pressure by efferent vasodilatation, so decrease protein filtration. Salt restriction is also very effective with ACE and ARB, and the benefit of ACE and ARB has been established in patients with diabetic nephropathy. So you can decrease proteinuria by the use of ACE and ARBs. Hypertension, target blood pressure 130 by 80. Again, ACE and ARB, the first line of treatment. And in addition to that, salt restriction, weight reduction, regular exercise, quit smoking. These features can control blood pressure, and it can delay the progression of the chronic kidney disease. Edema by salt restriction, fluid restriction, bed rest. Bed rest can lead to increased diuresis and decrease in edema. Thiazide diuretics are used for mild edema and loop diuretics for gross edema. Most of the nephrotic patients are often diuretic resistant. Diuretic resistant means you have to use the large doses of diuretics. You can combine loop diuretic with thiazide diuretics or metolazone. The role of albumin in the management of edema is controversial, because जितना albumin देंगे वो urine में निकल जाएगा. So what's the use of giving albumin? Albumin is quite expensive. So usually it is not given in patients with nephrotic syndrome. Resistant edema, not responding to loop and thiazide diuretic and above measures, then you may need to do a dialysis so that you can remove the edema fluid. You have to control hyperlipidemia to prevent cardiovascular diseases, and use of statins to decrease cholesterol, and gemfibrozil to decrease triglycerides. But before starting them on statins or gemfibrozils, you have to check the level of uric acid, cholesterol, because one of the side effects of statin is myositis and rhabdomyolysis. So before starting treatment for hyperlipidemia, you have to first correct the uric acid level. Hypercoagulability, risk of arterial and venous thrombosis, like renal vein thrombosis, which is a serious disorder. DVT is a serious disorder. Loss of anticoagulant protein, antithrombin 3 and plasminogen, increased platelet activity. These all are the features which can lead to hypercoagulability. And of course, serum albumin less than 2. And the treatment, if the diagnosis is the hypercoagulability established, you have to use low molecular weight heparin, warfarin, antiplatelet drugs, and aspirin. Infections, it's a major cause of morbidity and mortality because of loss of immunoglobulin in the urine. Immunosuppressive drugs can also lead to more infection. You have to give them pneumococcal vaccine so that they are prevented, annual influenza vaccine. And for opportunistic infection, you have to use prophylactic antibiotics if needed. Now, specific glomerular lesions, we will just briefly discuss minimal change disease, membranous focal segment, and focal segment. All these basic lesions are also seen in the secondary glomerular diseases. Primary is called idiopathic nephrotic syndrome, and secondary is the secondary glomerular disease. And this you can establish with the help of history, examination, specific investigations. And these specific investigations help in the diagnosis of secondary causes of nephrotic syndrome. For example, hepatitis B will point towards the hepatitis B related nephrotic syndrome. Hepatitis C can guide you towards the hepatitis C related causes of nephrotic syndrome, diabetes mellitus. These are the secondary investigation, specific investigation, which will help in establishing the secondary cause of nephrotic syndrome. Minimal change is the more, as I have already told you, most common cause in nephrotic syndrome in children and adults is 10 to 15%. Light microscopy and immunofluorescence are normally, now you find normal glomerular. That's why it is called minimal change glomerulonephritis, normal glomerulus. Electron microscopy, yes, you find diffuse effacement of podocytes. Food process, I have already shown you podocytes in the diagram which I showed you of the glomerulus. T cell dysfunction, podocyte damage. The treatment is high dose steroid, 1 milligram per kilogram per day for 4 to 16 weeks, and then gradual tapering up to 60 months. Complete cure is obtained in 90% of children and 75 of adults. Frequent relapse is called steroid dependent minimal change. Steroid resistance we have already discussed, and for these you can use cytotoxic drugs and cyclosporin. Now, secondary causes of minimal change disease. You see, minimal change disease usually seen in the extreme of ages, either in very young people, that is children, or in the middle age or higher middle age groups with patients with Hodgkin lymphoma. Drugs or use of NSAIDs can also lead to nephrotic syndrome, secondary nephrotic syndrome. Focal segmental glomerulosclerosis, this we will discuss along with the when we discuss nephrotic syndrome, but some glomeruli are affected and only segment of affected glomeruli. When we discuss rapidly progressive glomerulonephritis in the nephrotic syndrome, I'll show you a diagram of FSGS. Only segment of affected glomeruli, 20% adult nephrotic syndrome. This is the nephrotic syndrome in which you will find hematuria and hypertension. Light microscopy, as I have said, some glomeruli affected and only a segment of glomeruli affected. Electron microscopy will show effacement of the podocyte foot process. Treatment is high dose steroid, 1 milligram for 12 to 16 weeks, cyclosporin, but relapses are common, and the prognosis overall of FSGS is 50% develops end-stage kidney disease within 10 years. The secondary causes of FSGS is familial FSGS, HIV, drugs like pamidronate, interferon, SLE, if positive for C3, C4, CQ, IgA nephropathy. IgA nephropathy is not usually a cause of nephrotic syndrome. It is basically a cause of nephrotic syndrome. But yes, patient can present with nephrotic syndrome, reflex nephropathy, gross obesity, and renal agenesis. Means one kidney is absent, the other kidney is overworking, and patient can develop secondary FSGS. The secondary FSGS is not treated with immunosuppression. We have to treat the underlying cause. If, for example, if the person is obese, you have to treat obesity. If somebody has got IgA nephropathy, you treat IgA nephropathy. If somebody has got SAD, you treat SAD. Membranous, 30 to 40% of adults, slowly progressive, more common in male 2:1. The hallmark of membranous glomerulus, that's why it is called membrane. It is the thickening of the glomerular basement membrane. Spike and dome pattern is seen when you stain the glomeruli with silver stain. Subepithelial deposits are seen on electron microscopy, and immunofluorescence show IgG and C3 deposit. Treatment is ACE inhibitors and ARB for all patients. Steroid alternating with cytotoxic drugs, and cyclosporin is also used. The mainstay of treatment of nephrotic syndrome is steroids, followed by immunosuppression consisting of cyclosporin and immunosuppressive drugs. The secondary causes of membranous are SLE, malignancy, hepatitis B and C, drugs, and we have to treat the cause. Membranoproliferative children and young adult, 5 to 10% of nephrotic syndrome. Light microscopy will show you large lobular glomeruli. There is proliferation. That's why it is called proliferative. Proliferative of the mesangial and endothelial cell, double counter because of the proliferation of the mesangial cells and endothelial cells. The glomerular basement membrane gives an appearance of tram tract, double counter glomerular basement membrane. Type 1 and type 2 are there, dense deposit disease and circulatory immune complex. It is a 50% cause of nephrotic syndrome. Again, it's a bad diagnosis of nephrotic syndrome in the sense that patients do have hypertension, hematuria, and renal insufficiency, and ultimately they'll end up with kidney failure in 60% of cases within 10 years. Treatment is low dose steroid. The secondary causes of MPGN are SLE, hepatitis C, malignancy, cirrhosis, heroin abuse, and you have to treat the secondary cause, which may lead to remission of the disease. Now the key points. Nephrotic syndrome is a major cause of edema. The clinical hallmark is proteinuria of more than 3.5 gram, hypoalbuminemia, hypercholesteremia, and edema. You have to remember these features of nephrotic syndrome. Many causes: primary minimal change disease, MPGN, FSGS, and membranous pulmononephritis. Secondary causes importance are diabetes mellitus, SLE, drugs, malignancy, and infection. Kidney biopsy establishes the diagnosis, which is usually performed in patients with nephrotic syndrome. Management is general management, specific management, and treat the secondary cause. Untreated nephrotic syndrome may lead to progression of the disease and development of chronic kidney disease, which may ultimately lead to end-stage kidney disease. This was about nephrotic syndrome. In the next lecture, we will be discussing the other glomerular disease, which is called nephritic syndrome, which is a relatively serious disorder as compared to nephrotic syndrome. Thanks. Sure.